Hi everyone, my name is Olivia Harkins, as you may know, and today we are going to be discussing intracranial hemorrhages and the implications to the field of forensic pathology. This is a literature review, so let's get started. So this slide details my abstract as well as the goal of this literature review presentation. So within the intracranial space of the skull, specifically within the brain's parenchyma and the surrounding meningeal spaces, there can be bleeding, which is referred to as intracranial hemorrhage. There are four specific types of intracranial hemorrhage, which includes epidural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and intracerebral or intraparenchymal hemorrhage. And these are distinguishable based on the location, of the brain in which they occur. So epidural hemorrhages can occur due to blunt force trauma or perforating head injury, and these hemorrhages typically present with a fracture of the skull and subsequent damage to the middle meningeal artery. Subdural hemorrhages have a pretty similar etiology between blunt force trauma or perforating head injuries. However, instead of blood entering the epidural space, they are now entering the subdural space as a resulting from tearing of the bridging veins off of the superior sagittal sinus. Subarachnoid hemorrhages typically result from a weakness in a vessel wall or an aneurysm, which subsequently ruptures. And intracerebral hemorrhages or intraparenchymal hemorrhages typically result from intrinsic causes instead of trauma, such as hypertension, vascular malformations, and aneurysms, as talked about before. So intracerebral or intraparenchymal hemorrhages are the most common type of intracranial hemorrhage, with an incidence rate of about 24.6 per 100,000 persons per year worldwide. And there are about 53,000 cases per year in the United States alone. The 30-day mortality rate ranges anywhere from 35% to 52%, and only about 20% of survivors are expected to have a full recovery after 6 months. It's within these first 24 hours that approximately half of the mortality occurs, and this is due to intracranial hemorrhages having such unique etiologies and numerous clinical presentations. Talking about the mechanism, again, I want to detail more of what a traumatic brain injury is and how this can cause an intracranial hemorrhage. So traumatic brain injuries, or TBIs, are typically encompass any disruption to the brain's function caused by a bump, blow, or penetrating or perforating head injury, and these can range in severity, which therefore can cause intracranial hemorrhages to range in severity as well. With up to a 50% mortality rate, traumatic brain injuries and resulting intracranial hemorrhages constitute a portion of forensic examination cases, which us as pathologist assistants can encounter in the forensic setting. So we'll go a little bit more into detail about that. Overall, the goal of this review is to explore the etiology of intracranial hemorrhages through traumatic brain injury, its relevance to the pathologist assistant profession, specifically in the forensic setting, and talk about how new technology can be of use in this field. This picture also is a good illustration of what an epidural hematoma or hemorrhage looks like and the space that it's in versus a subdural. Over here is a subarachnoid, cut off by my face a little bit, and then an intracerebral hemorrhage. So hopefully this gives you a good idea of what we're working with in a cartoon form. So now on to our literature review portion of the presentation. There were 3 articles that were reviewed as detailed in this slide. And the first article we're going to talk about is The Pathology of Traumatic Brain Injury, a Practical Approach by Safa El-Sarj. And this provided a detailed look at traumatic brain injuries and how pathologists frequently encounter these pathologies in the coronal and medical legal services. So in westernized society, TBIs are considered the leading cause of death and account for 25 to 33% of all traumatic deaths. Therefore, it's important for pathologists and pathologist assistants alike to have an extensive understanding of the anatomy when performing these autopsies, as well as be familiar with the mechanisms of intracranial hemorrhages and how they come to be. So moreover, it's essential to discern the location of the hemorrhage, the potential source of the hemorrhage, as well as whether or not the hemorrhage is old or new. So the King's College Hospital over in England was used for this study, and this reported that 39% of traumatic brain injuries resulted in epidural hemorrhages, of which 96% of these were associated with a skull fracture, and 98% of these were associated with a scalp bruise or contusion. Subdural hemorrhages accounted for 47% of the traumatic brain injury cases, and microscopic examination was proved to be extremely beneficial in determining the timing of the bleed regarding macrophage infiltration, hemosiderin pigment deposit, and the extent of granulation and fibrous tissue formation as well. And then there were subarachnoid hemorrhages that were frequently presented with a film over the dorsal surface of the brain, resulting from that shearing damage to vessels due to the rapid acceleration and deceleration of the brain, or from a Berry aneurysm. And overall, the gross identification and serial dissection of the intervertebral arteries for histology were found necessary for the differential diagnosis. And it was important to be able to differentiate whether the intracranial bleeding was due to a stroke or due to a head injury. And the pathologist assistant and pathologist assistant therefore must be able to correlate autopsy findings with clinical history of the decedent if that is made available. So then we have a picture or image here, which details a little bit more about the gross presentation of intracranial hemorrhages. So the first picture is of an epidural hemorrhage. The second picture is of a subdural hemorrhage. This one is of a right subdural hemorrhage, which resulted in the compression of the right hemisphere. We then have a countercoup contusion on the inferior surface of the left temporal lobe. We have a coup contusion on the dorsal lateral surface of the right parietal lobe. We have a burst temporal lobe. We have trauma to the brainstem. We have a subarachnoid hemorrhage. And then last but not least, we have trauma to the vertebral arteries, which then resulted in a subarachnoid hemorrhage overall. So the next study sought to further correlate skull base fractures with the incidence of intracranial hemorrhages with patients with TBIs. So the authors studied a population of about 9,006 patients, and these were divided into 3 subgroups. Group 1 had head injury with no intracranial hemorrhage. Group 2 had head injury with a single intracranial hemorrhage, and Group 3 had head injury with multiple intracranial hemorrhages. There was found to be a significant correlation between head injury severity and skull base fracture locations towards the intracranial hemorrhages seen on computed tomography or CT scans of these patients. So patients with anterior fossa skull base fractures most likely had epidural hemorrhages, and this was in comparison to patients with middle fossa skull base fractures, which correlated more to just having a cerebral contusion. And then the last study reviewed in this presentation was by Tapero and other authors, and this evaluated the benefits of using postmortem computed tomography, or PMCT, to locate intracranial hemorrhages in advanced stages of decomposition. So this case, or this article in particular, had a huge impact on the profession as pathologist assistants and being a pathologist, as this can be helpful in evaluating decomposed bodies that would otherwise be difficult or near impossible grossly due to the deterioration and putrefaction of the brain. So the authors found 11 cases in which the body was decomposed, and a post-mortem CT scan was taken and an autopsy was performed. So of those 11 cases, all 3 of that criteria had to be met. Again, body was decomposed, postmortem CT was taken, and an autopsy was performed. And grossly, the presentation of the intracranial, or the presence of the intracranial hemorrhage could be identified, but it was the specific location that couldn't be ascertained due to the liquefied state of the brain. So the postmortem CT was taken before evisceration to localize the intracranial hemorrhage and validate its presence, and all these findings were determined to be useful in determining cause and manner of death in the long run. So in all 11 cases, they used the postmortem interval 2 days to 2 weeks, and the postmortem CT showed intracranial hemorrhages of at least 5 millimeters in size, 8 of which were intraparenchymal hemorrhages with no associated skull fractures, which I thought was interesting. And then of the 3 cases, one had subdural and subarachnoid hemorrhages with an associated skull fracture. Another case had a subdural hemorrhage with an associated skull fracture. And then the last case had a subarachnoid bleeding with no fracture present again. And 72% of the 11 cases had intraparenchymal hemorrhages, which were attributed to being likely fatal. And this image here is a photo from that study in which there's a comparison of the CT results, in which we can see that hemorrhage over here with those of the autopsy, in which the brain basically poured out of the skull in a liquefied state. So once again, ascertaining the location of that hemorrhage was more or less impossible after evisceration, such that postmortem or having that CT scan done before evisceration was proved to be extremely beneficial in locating and validating the presence of that bleed. So going a little bit more in depth to the pathologist assistant's role in a forensic setting and how intracranial hemorrhages can relate to this, it's necessary to correlate the decedent's medical information prior to death, if it's available or accessible, to findings at the autopsy. This includes an in-depth growth description of the findings as well as tissue submitted for histological analysis. So some of the clinical presentations of intracranial hemorrhages include headache that gets worse, vomiting, drowsiness, dizziness, progressive loss of consciousness, confusion, unequal pupil size, slurred speech, and loss of movement or paralysis. And grossly, it is likely that the PA will find some evidence of contusions, lacerations, ruptured vessels as a potential source, a collection of blood in one of those spaces, if not more, as well as a compression of structures or a dilation of structures due to that accumulation of blood, depending on its location. So overall, it's important, again, to be able to correlate the suspected mechanism of death with what is grossly identified, especially the location of the hemorrhage and what intracranial arteries and or veins are affected. And further, the PA's role in this is, again, to have that gross identification of that hemorrhage. Hopefully, it's going to look something like this, very evident. Or to have a classification and location of where this intracranial hemorrhage is at, and what that could have meant for the patient's demise, as well as an evaluation of intracranial arteries. As we can see here, this is a ruptured vertebral artery, and we can see it going from normal to then slowly getting more pathologically affected. So that is part of the relevance to a pathologist assistant. So in conclusion, the accurate identification and classification of intracranial hemorrhages are of great importance to the practice as a PA, particularly when it comes to a consensus of manner and cause of death in an autopsy as determined by the pathologist. It is through a pathologist assistant's knowledge of anatomy that the PA can discern the location of the hemorrhage. And it is through a PA's understanding of what vessels are affected that we can determine the pathological correlation, as well as the presentation with the severity of the bleed, and overall lead the pathologist to determine what may have caused the decedent's demise. And as we continue to make technological advancements, as we see with these CT scans, helping ascertain the location and severity of the bleed, hopefully we can continue to fund more for technological resources in the lab so that some of these cases with extra obstacles and hurdles can be overcome and a proper resolution can be found. Here are my references, and I hope you guys learned a little something about intracranial hemorrhages, its relevance to the practice as a pathologist assistant, and again, what technological advancements we can continue to make our jobs easier. Thank you guys!